Hi, good afternoon, everyone. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. We are very excited to invite Dr. Shams Iqbal again back to the hot seat to talk to us about another procedure that he does provide here at Newton-Wellesley Hospital, uterine artery embolization. Next slide, please. And we just want to tease our upcoming lunch and learns for the next 3 weeks. We have a couple of orthopedic talks back and forth on the knee and then the shoulder, thanks to Lori Katz and Sean Rocket. And then, of course, we have our chair of medicine talking to us about how I approach the abnormal liver functions. Once again, a reminder that these talks are archived on our intranet Newton, as well as up on YouTube. Go ahead if you missed a talk and you can check those out. Next slide. I wanted to remind folks about this because we are paying for through November 2022. This gives you +1 access to great information about things you might need in your house. It's a personal assistance program, trying to find the right person to shovel your driveway, trying to find the right person to get your lawn ready for spring or to fix your tree. We don't want Shams climbing up the tree and doing some tree surgery. You go ahead, you can send an email to these folks and they will find 3 people in your community who have been vetted and will come and do this and give you estimates. They'll make appointments for it. They'll do anything you like. And it's really a simple service, non-intrusive. And I've certainly used it personally a few times and I would strongly recommend it. Please go ahead and sign up for that. Very simple to sign up, going to communities.circles.com and typing in NWH. Next slide, please. And then we wanted to remind folks that this benefit's going away through June 1st. Shipley Fitness Center is free. Can't complain about their hours that you can't have time to make it. They open at 4:30, close at 10 o'clock Monday to Friday. And oh yes, they're open on the weekends as well. So you can't use that as an excuse. 5 a.m. to 6 p.m. Go at least check it out once while it's free. You may actually like it. We only ask that you fill out that health appraisal form to make sure you're going to be okay to exercise. Any questions, please contact our friend Daniel Destin at the Fitness Center and he'll get that going for you. Next slide. This is a new one that we wanted to remind folks. The March 30th is Doctor's Day. We want to welcome back people to our hospital. Come by bowls 4 and 5 between 7:30 and 12:30 to pick up a cool branded water bottle, as well as a gift certificate for a free breakfast or lunch. We're not yet at the point where we could serve breakfast and lunch, although we're getting there. But you go ahead and pick up the certificate, pick up the bottle, and then go have a breakfast on us. No, you can't come by and pick up 9 certificates and 9 bottles for everyone in your office, but just 1 per customer. We want to get people back in the office. Also, at the same time, we're going to be having a professional photographer there. If your photo is old and outdated, please come in professional dress and we will take a brand new picture for you at no cost to you, and we will get that up on the web, on Epic, and also on your brand spanking new ID that is coming down the road. Next slide.
Great. Quick question. Yeah. How about if somebody's not around that day? Any alternate for this option?
Yeah,
sorry.
I think, we can work something out. This is one of those things where I'll say while supplies last, Shams. So if you're not around, you can definitely contact me or Audrey and we'll see what we can do.
I will try to do that. Thank you. Appreciate
sure.
it.
Next slide.
All good work.
I think the rest is yours, if I believe. If I'm right.
Yeah.
Okay, I'm not going to talk about uterine fibroids, so I'll leave that.
Maybe you can try. I know you can do. You wear a lot of hats. Maybe this one too.
Shams, thanks for being here. Appreciate it.
No problem. Thanks everyone, and thanks John for having me back. And I really liked the last discussion which we had on prostate artery embo. And I see the community was very involved, and I have interacted with a lot of you, the providers. So today we will be talking about uterine fibroid embolization, a similar thing in the females, which is very common. So this is our team. I remember I was told that we should introduce our team. So last time we were just 2 of us. When I presented, it was me and Carlos. Now we are 4. So I'm on the left side, then Carlos Jerome, Diana Den, and Ali Adesani. This is what makes the Newton-Wellesley dedicated team, but we do have other physicians covering us from time to time. So again, we'll be talking about the uterine fibroid embolization, and this is how I'm going to approach the talk: introduction, overview, and talking about the indication, contraindication, how we do it, what we do, what to look for, and eventually follow up. So if you have any questions at the end of the talk, we can discuss. Again, fibroid. By definition, fibroids are the most common benign tumor of our body. They are abnormal growth of myometrium. They're not malignant, they're benign. They cause problem by virtue of the hormone and their locations. So they are driven by hormone, as I already mentioned. So this is how they look like in the lifetime of a female. it's estrogen dependent. So with estrogen, they tend to grow. And as long as you have estrogen, which is still menopause, it keeps growing. And then post-menopause, they are devoid of their estrogen and they start going down. But if they have HRT or any tumor which is hormone dependent, they can grow back again. However, the vast majority of the patients who we treat for this is in the range right before the menopause, about like 30 to 50 years of range. Like usually around 40 is the more common age. So burden of disease is, as I said, it's a very common. Almost 50% of the females will have that, and it's a little bit more, quite a bit more common in African American because of genetics and the way the disease is distributed. And about like half of that percentage is in white women. So we see much more commonly these things in young female African American females, and the cost involved is huge just to manage this. Overall, it's like, and this data is from about 10 years ago. It was 34 billion. I'm sure right now it's in the range of $60 billion to manage the entire direct and indirect cost for management of the fibroids. So therapy options, how do we manage? The most common and standard management is medical management. You have hormone imbalance, we try to balance the hormones. So we have progesterone pill, progesterone depot, and all those things, which is mostly managed in the community and in the gynecological offices. If it is not managed by that, we start looking for procedural/surgical interventions. The most famous and the most like historically like understood is hysterectomy. However, the issue with that is you lose the uterus, and a lot has changed in the past. So in historically, it used to be like complete hysterectomy, then they will leave the stump behind, the cervical stump. So technical changes have come, but now we have reached to the point where we do myomectomy, where they go with a scope and look for the fibroid and take it out, macerate it and take it out. And along the way, like other fields have also been looking at it, which includes us, IR, and we have a technique which can be valid in a lot of organs and systems. So in 1997, the first uterine fibroid embolization with the intention of treating for fibroid. Before that, we used to treat, but it was mostly for bleeding, like postpartum hemorrhage and other situations. But just for fibroid indication, that was the first time it was treated. And since then, we have been growing leaps and bounds, trying to prove it with like studies and research and all those things. In addition, there are other modalities which are ablation, the most famous of them being HIFU, which is MRI guided. It's a MR intensive treatment, non-invasive. However, it takes a long time and it's not as effective. So still research is in progress. So today we'll be focusing on uterine fibroid embolization and also their head-to-head comparison with myomectomy. This is a standard from our society of IR, which says like, when do we treat them? It's just isolated one-off slide here, but I just want to express that we also look at from a standpoint that the patient should need the procedure, patient should be a good candidate, and patient should be expecting benefit from the procedure. So the most common indications are menorrhagia, heavy bleeding, which is very intuitive because somebody is bleeding from hypervascularity, and we treat by virtue of blocking the vessels. So it's very intuitive, and it has the best outcome in patients who are bleeding as the primary concern rather than mass effect and other things. Severe menstrual cramping, pelvic pressure, which is like because of the size, they start pressing on different organs. If you press in the back, you have constipation in the front, you can have urinary issues, and that leads to infection and other things. And hydronephrosis, like there have been patients, again, in this country, I don't see much, but I do a lot of global work. When we go to Africa or other countries, we still do see young females with no other disease process going on, large fibroids. And as I said, like the African American community, they have large fibroids compressing upon the bladder and the ureters, and they have obstructive uropathy and renal failure. So their life is shortened because of the benign cause leading to another benign issue, and they don't survive much because chronic renal failure has a very low 5-year survival, as we all know. So it's a pathetic situation that like people will lose their life on such small things, simple things, which can be managed with surgery or like even minimally invasive procedure like us as a daycare surgery. So when this started, of course, we have to prove, and just like any other treatment, we have to, if it's a new treatment, we have to show the efficacy. But if there's already a treatment, what FDA requires is like you have to do a comparative study and say like it's not worse than the previous treatment provided. So the first trial which came out was like EMI trial, which was in Netherlands, and they did like 177 patients. They did evaluation, clinical evaluation. Clinical evaluations are a little weaker evaluation in terms of objectivity, because they have a lot of subjectivity involved. And to the point that like right now, presently, most of the studies which you do in prostate and in things which are not black and white, we do standardized validated questionnaire, which the other studies will move to, as you will see. They did the 2 years and 5 years evaluation in these patients, and it was said like it's safe enough, and 2/3 of the patient can be avoided the hysterectomy. And at that time, they were also moving towards hysterectomy. And so comparative UK published another trial, the REST trial, in which they looked for, UK is in a very advantageous position for studies like this kind, where you can do head-to-head comparison, because they have a centralized system. The payment is not a big issue because everybody is salaried, so they don't have much incentive to pull in one or the other direction. So they have these studies where they can do comparative between two different branch and same outcome procedures of surgery. So they did their study, and they started using the HRQOL, which is health-related questionnaire of life, quality of life questionnaire, and that showed that like there was not significant difference. However, they say like significant increase in complication rate, which I still don't understand, because maybe it's in the 2010s it was like that because we were admitting these patients. We were technically not as refined as now, because now we have reached to a point where like I do it as an outpatient. The patient comes, do the procedure, and discharge, and they have been doing fine. In the last like 5-7 years, I have done outpatient. Before that, I was also admitting the patient, but now we have done some changes, which we'll talk about. Like for one of the things is superior hypogastric block, which I will talk about. So the latest trial, which was published 2 years ago in EJM, was the Semitrial, and this was a pretty big trial and a lot was done. However, the conclusion was a little off because they did not see significant difference between those two procedures, the myomectomy head-to-head and UAE, uterine artery embolization. However, they say that myomectomy is superior, which is okay, but the base on which they formed this statement was rather weak. And in addition, there are a bunch of other things, as I said. In this, they were admitting patients after UAE for 2 days, which does not make sense in this day and age. Like, this is an outpatient-based procedure. And they had like very high bleeding rate, which I have done like hundreds of these, and I've never had bleeding, at least in the uterus. So I don't know who was doing the uterine fibroid part. So this is the same trial which is talking about all the complications. For the sake of time, I won't go dig deeper into this trial. So this is a very important slide, which it's like, so after all these studies, you do a global evaluation, which is done in Cochrane website. The Cochrane report says like, uterine fibroid embolization is as good as the myomectomy, and the reintervention rate is a little higher. But again, this is looking at the back, but now coming in the future, I don't expect the reintervention rate will be too high. And the fertility wise, there was a question, low evidence of low fertility, because they always talk about fertility being low after UAE. So I did my own, I dig deeper into this field. So fertility is not a big issue after UAE, because if you look at general population, the average fertility for a female in her reproductive age is 66%, which is 2 out of 3 females will be pregnant. All things standard, no changes. Once they have fibroid, that falls to about 35 to 40%. And the studies show that post UAE, the pregnancy rate is still 38%, which is hardly much change. So yes, compared to someone who is completely normal is 20% low, but for those who have fibroid, and that's what we're treating, is pretty much the same. So that data is not founded on good, sound understanding. Again, jumping to the procedure now, like moving gears. So as I said, like the first time we did the procedure as a field was in 1997, and it was published. And since then we have done a lot of work. So it was several, like it was faster recovery compared to hysterectomy or myomectomy. And the chances of future pregnancy should be higher because we are not approaching the endometrial aspect. When you do a myomectomy, you go through the endometrial aspect. So once you do any procedure, there are scars, there are other things, changes happen. That leads to decreased chances of future pregnancy. We approach it from the outside. When you come from the outside, we don't affect it as much. However, yes, hypovascularity can lead to fibrotic changes, but not as much as when you hit it directly. Outcomes, when you have fibroid, size is a problem. At about 3 to 6 months, the fibroid size reduction is about 50 to 60%. The uterus moves a little slower because it's like the fibroid does not compare, has takes the whole uterus. So the whole uterus is decreased size is a little bit less, 40 to 50%. Bulk symptoms, as I said, like pressure in the front, pressure in the back, it decreased by almost 88 to 90%. Resolution of menorrhagia. This is the most important, and I've highlighted like it's more than 90% because bleeding is the issue and we are blocking bleeding. And successful elimination of symptoms, again, it's a questionnaire thing, almost 80 to 90%. So the largest, as I said, like since we started doing this, SIR has been big into it, and there are a couple of people who really lead this. Gary Siskin at Albany is one of the leaders in this, and he started the SIR Fibroid Registry. And so far, we had, last I checked, about 2,700 cases who have been followed for 1 year, and there was 87% significant improvement in the symptom score. At 3 years, 85%. Pretty decent score. Huh? Recurrence and complication, as I said, overall repeat rate is about 15%. Amenorrhea, again, if you are younger than 45, it's like roughly 2%. And if you're more than 45, you're already approaching menopause, it's about 20 to 40%. You can have vaginal discharge because of the mucoid discharge from all the treatment changes. Transcervical fibroid expulsion, this happens like about 3 to 15%. In fact, when we evaluate the patient for treatment, we look at the MRI closely for two things. One is like if it's something is serosal with a tiny pedicle, because if you treat them, they can detach and they can be a foreign body in the belly. So we closely look at that and we don't offer this treatment to them. If somebody is in the submucosal area, and if it's like not more than 50% base, they can be expelled. If it's small, less than 3 to 5 centimeters, they can expel easily with the next bleeding cycle. If it's bigger, then you have to tell them like, this is a chance. And in fact, like my one patient about last month, she had a bigger thing. So I informed her, and she expected that in the next cycle, she did pass a large fibroid, a big clot, which was pretty much the treated fibroid, very like grumous material. Sepsis, uncommon. DVT and PE, anything you treat and you ask the patient not to be active, they can have DVT. Non-target embolization, this is like when you treat the fibroid and the beads which we use can go to different organs and structures. That's very uncommon because we can see that when we're treating. So you have to be cautious to have that non-target embolization. Absolute contraindication, viable pregnancy, of course, we cannot do that. Active infection, we avoid that. And suspected malignancy of any kind in the pelvis, we don't treat this because then it becomes a surgical candidate. We do treat at times, but that's just to decrease the blood supply for pre-surgical preparation. Relative contraindication, coagulopathy, allergy, and renal impairment. This we can manage in different ways. We can use less contrast if it's like borderline renal impairment. If you have coagulopathy, we can correct it. Contrast allergy, we can prepare the patient with steroid and hydromorphone to prepare the patient for the contrast allergy. Consultation, as I said, like all these patients we see in the clinic, we talk to them about their signs, symptoms. We try to understand their primary problem, because if we are going for pressure symptom, it will take a long time, about 6 months or so, before the patient will feel good amount of effect. And if the patient has primary concern as bleeding, the treatment effect will come right away in the very next cycle. So we try to understand their concerns and problems so that we can figure out like how well we can help them down the road. And then we look for imaging and we consider other things. MRI, as I said, MRI is a very important factor which we look for, and it gives us the size, shape, location, and number, and all these things, and the enhancement. If it's like sometimes fibroids are like calcified, they don't enhance, and no matter what you do, you cannot treat it from a vascular approach. So you have to treat it from a different approach, like surgical, because so enhancement has to be shown because that's a prognostic factor for treatment outcome. And procedure-wise, as I said, like we need to access the blood vessel, and we look for which way we need to go. It could be radial or it could be groin. I prefer mostly groin, but in this case, in this set of patients, as I said, these are younger patients, we approach with radial because this leads to much higher mobility right after procedure, because they have a TR band in the wrist and they can, right after the procedure, they can walk around. With the groin, they have to lie down for at least 2 hours, if not longer, post-procedure. And that's when the DVT and other problems come up. So we have been working on transradial access of late. Anatomy, so as we all know, like anything in the midline, the way God, if you believe in God, has designed us, anything midline has bilateral supply. So uterus being a midline structure, it is supplied from both sides, both anterior division of internal artery, the first or the second branch is the uterine artery, and when the uterine fibroid is enlarged, the artery becomes bigger, so which makes it much more convenient for us to go and select. And you have to treat both sides, because if you treat one, the other side will become bigger and they will supply the fibroid. So unless you treat both sides, you will not have a good outcome. And this is how a fibroid looks like. This is the right groin axis. We go and curve back up, use the microcatheter and injection from here. These are the main vessels and the corkscrew vessels you can see. And this is the enhancement of the right hemisphere of the fibroid. And this is counterpart, the left hemisphere of the fibroid. And we both embolize both sides always. As I said, radial versus femoral approach. And for the radial, we can go from the top and we can go right and left. From the groin, we can go from the one side, and we have to create a loop known as Waltman loop, which is very famous in the IR literature. And otherwise, it's challenging. So we use a different catheter. Anyways, more technical. What do? We block it with particles. So this is how they come. They come in pre-filled syringes, which are sterile, and they are floating in saline. We take the saline out, mix with contrast, and once we are reaching to a point where we need to reach, we infuse the particles and ensure that all the blush is gone. Historically, when we started doing this, we used to do with the polyvinyl alcohol, and it's the way polyvinyl alcohol is made is by they take a big chunk of PVA and you cut the corner. So it's like those are semi-linear structures rather than spherical. In the last 20 years, the field has moved to completely spheres. So, excuse me. So we have much better control of the embolization effect of the vessels. And right now we do like 5 to 700 or 3 to 500 at the most, because 350 to 400 is the size of the like shunting to the ovaries. If there's any risk of ovarian, you should use bigger particles so they do not cross to the shunting side. So what I was referring to, like initially there were a few studies which show some failure with PVA because they were not able to block the blood cell completely. So now we use spherical, so the outcomes are much better. And the end point is like to and fro. So when you inject, again, it's something that you have to see in a live video. You inject and the blush of the fibroid is gone and the vessel goes back and forth. The contrast in the vessel goes back and forth. And we count till 5 heartbeats. Once we reach to that, then we stop. We don't treat. Just like in this case, you can see this is before the treatment. You can see a lot of blush, and post-treatment you can see this is from image from Michigan. One of my friends used to do that. They will have both axes, both groin axes, so they can treat both sides at the same time, avoiding much radiation, like making the radiation exposure to 50%. But you're left with like 2 axes, so double the risk of axis-related issues. So this is pre-treatment and that's post-treatment. You don't see any, you see the big vessels, but you don't see the blush of the tissue. Peri-procedural care, as I said, like pain is the biggest problem of these procedure, because once you embolize that, the fibroid starts dying and they start releasing humoral material, all the cytokines, and that can cause a lot of pain. So we used to give, first of all, initially we would admit them overnight for a couple of days. Then we started admitting for one night. Then we started giving them a lot of pain meds and trying to discharge, but that didn't work. So now what we have moved to the point that we started doing hypogastric block. The superior hypogastric nerve plexus is the plexus right in front of the L5 vertebral body. I'll show an image of that. And it supplies the entire pelvic structures. So what we do, like we go in and we inject like long-acting local anesthetic with steroid and some alpha blocker, and that keeps the area numb, and that helps us in decreasing the pain medication which we give them before we discharge them by a significant margin. As this study said, like there's a significant change in the pain requirement with the block. So this is the block which you do, like there's a needle which we target to the lower edge of the L5 vertebral body, go straight through it, very tiny needle, about 22 gauge. And we give a mix of bupivacaine, canologue, and clonidine, as I mentioned. And they have much significant better outcome, and they do not have much pain. So the pain requirement for Toradol reached almost 50% after this management. So I've been doing this since the last few years, and we are avoiding like any pain-related issues. In fact, one patient about a year ago, she was herself a physician. So physicians are the hardest patients. She felt very nice after the procedure for 2 days, and then she stopped taking her meds. And then suddenly she got so much pain that she had to come to the ED, and we had to go and explain her. And then we have to use much higher dose of pain meds to catch up. And then she was fine after that. But again, so I expressed the patient completely like very, very focused that no matter how you feel, how good you feel, you have to keep the pain medication going for 5 days at least. Again, in addition to that, the other technique which we use, like once we have done with the treatment, we use intra-arterial lidocaine. That decreases the pain medication requirement, because pain medications are like the opioids, which is what we give. They are a significant issue in the laws, and they have gotten a bad name in the last few years because of all the deaths and addiction associated. So we do a lot of hard work to avoid giving as much pain meds as we can. So antiemetics, of course, we always give them, and we give them Zofran, so that they do not feel nauseated, because again, all the changes of inflammation can be associated with the treatment. Follow-up, we talk to them in the 1 to 3 days after the procedure, then 1 week a phone call. At 1 month, we talk to them in the clinic. At 3 to 6 months, we do an MRI and see how they're doing and follow up if anything is needed, if something is left behind, which is very uncommon, but again, like we do it as a standard. So this is an example of one of the patients who had big fibroid, and this is pre-treatment, and the post-treatment after, like, this is about 6 months later, I believe. So there's like all necrosis, and this is citric cavities, and slowly they will release all the fluid and they will go away, much like the same in the second patient. Very like nice. And this is, as I said, like we look for the enhancement. If this enhancement are not as this smooth, we have to explain the patient that like the chances of improvement is not as great. But in these cases, they are very good candidate. Another patient, same thing. You see, I hope you guys can see my cursor. So big fibroid here, another big fibroid, and post-treatment, all of them are like non-enhancing, liquefying. Over time, they will like go away. So as you can see, even the fibroid is not enhancing, so they are not having any of those effects. The mass effect will still be there. It will take some time before they slowly resorbs and goes away. And that's why we talk about the difference in the pace of improvement of menorrhagia versus mass effect. And again, as I said, like if you have any patients who needs to be consulted and evaluated by IR, feel free to reach out to us. My email is up there, and my partner, Dr. Din, who will be leading this program, hopefully is there, and you can give us a call at these numbers also if you have anyone who needs to see us. And I'll stop at that. I went fast because I know time was of essence, so I think I caught up on time.
Yeah, that was great. Thanks, Shams. That's really great. If anyone has a question for him, go ahead and throw it in the chat box. I guess I'll start off. I have maybe 2 quick questions. One is there ever a risk or a chance of ischemia because you're knocking off the artery? And are there any ramifications of that? And then the second question, and then I'll let you answer both, is as a woman who's trying to get pregnant with a large fibroid, is myomectomy preferred versus this because of speed of removal of the tissue, or has that not been studied yet?
Yeah, so very good questions and very logical questions. Ischemia, like we do not take the entire blood vessel off. So you have to understand that, like, if you look at from the blood vessel and see like a cylindrical view, you have big vessels which become smaller. Eventually, we reach to a level of the capillary, which are roughly 6 to 8 microns. And from that standpoint, we are blocking with 500 to 700 micron particles. We are like significantly far off. So there's enough blood supply for the normal uterine musculature to survive, and they do survive. So in my 11, 12 years of doing this, I've never seen ischemia. So that's like touch wood, let's keep it that way. Second, myomectomy versus pregnancy versus UFI for pregnancy, that has been studied. So speed is usually not an issue, because if these patients have pregnancy issues, it's not going to happen in the very next cycle. So what, in my mind, what I would look for is like 2 big things. And each one of us have like one issue. One, like if you go to myomectomy, you abrade the site of the endometrium, and that can lead to a scarring and all those things. So that lead to a lot of ectopic kind of and early abortion issues because of like implantation at a non-standardized endometrium, and the myometrium is weak behind it. However, and the pregnancy also needs good blood supply, so we decrease the blood supply quite a bit. So we lack from that standpoint, and that leads to some scarring, not as much as the direct trauma. So looking at the data, we both have roughly like 35 to 40% pregnancy rate post-procedure, post-surgery. So it's like pretty much smack in the middle. It's just like the reason why I attested to it quite a bit is because the people who think that UFI leads to a lesser pregnancy rate compared to myomectomy. But I think at this day and age, after I dig deeper, it's pretty close to each other, and it's the choice. The speed probably is not a big reason to go after one procedure or the other. It's just the patient preference and the physician preference and the like available resources at that time.
Excellent. Shams, thanks very much for coming back, and we'll have to have you come back and learn about another cool procedure you're doing over there, you and Dr. Dean. So we appreciate
your help.
Everything you're doing for us, and we'll see everyone. Hope everyone has a nice weekend, and we'll see everyone back next Thursday for a talk by Laurie Katz about knee patella instability. Thanks. Bye.
Thanks, John. I appreciate it. Thanks. Your team is great.
Bye.
Have a good one. Bye-bye.